Imagine a health record system designed specifically for genomics. Because let's be honest, electronic health records are not built for genetics. Now you can stop imagining and start using, because Phenotyps is just this. Phenotyps is the world's first complete genomic health record system, with pedigree drawing, standardized symptom capture, diagnostic insights, and more, all in one place. Check them out at phenotyps.com.
How is it that we find ourselves surrounded by such complexity, such elegance?
The genes of you and me, the genes of you and me, we're all made of DNA. We're all made of the same chemical DNA. We're all made of DNA.
Hello, you're listening to DNA Today, a genetics podcast and radio show. I'm your host, Kira Deneen. I'm also a certified genetic counselor practicing in the prenatal space. On this show, we explore genetics' impact on our health through conversations with leaders in the field, experts like fellow genetic counselors, researchers, doctors, and patient advocates. In this special extended installment, we are recapping and reflecting on a few sessions from this year's virtual NSGC conference. Thank you for waiting for this episode. Typically, we release new shows on the first and third Fridays of the month, but we wanted to wait until the conference was over so we could record and release this episode as we reflect back on it. So to kick off the show here, we have Aishwarya Arjunan joining us, who was the NSGC 2020 Leader in Advocacy Award winner. So congratulations and thanks so much for coming on the show today.
Thank you so much for having me.
So you're also the co-chair of the NSGC Diversity and Inclusion Task Force. For those that may not be familiar with the task force, can you fill them in on what the objectives are and what the task force is really aiming towards?
Sure. So Julia Platt and I were the co-chairs of the Diversity and Inclusion Task Force for NSGC in 2019. And we actually, out of that, came up with the advisory group. And Deepthi Babu and Ambreen Khan were the co-chairs of that this year. But the task force initially was really kind of brought together to provide recommendations for NSGC as an organization on how to go about addressing diversity, equity, and inclusion within the organization, the community, the profession, et cetera. And it was a group of about 15 people, 15 members. And what we did, actually, I would, to kind of shorten the answer, would definitely suggest taking a look at the summary report that we published in the Journal of Genetic Counseling this spring. We really wanted to be transparent with our work and process, so we decided to write it up so that everyone had access to what we did and what we suggested. But the main recommendation that we came up with from that process was really to hire an external DEI consultant. We as a task force didn't feel that we were best suited to guide the organization through the process. We felt that we could provide advice and suggestions, but we're all genetic counselors. None of us are diversity, equity, and inclusion experts. That's not our job. Though we might have experiences and feelings about those areas, we didn't think we were really the right people to say, these are all the things that you need to do to create lasting change within the profession or organization. So we really wanted people that were experts that we could commit resources to, that could really help us guide the organization through the future and through all the steps that we needed to take to create kind of lasting or sustainable changes. One of the other recommendations that we also made outside of the DEI consultant was really for NSGC to kind of start thinking about an organization-wide universal design plan. So universal design refers to the layout and composition of our built environments, virtual spaces, and information that's really accessible to all people, regardless of disability, spoken language, whatever other characteristics there might be. And really, the adoption of universal design is intended to ensure the accessibility of resources and products and events to every NSGC member or potential member. And the goal of improved accessibility really also extends to patients served by the profession. So one easy example could be from this AC, the closed captioning that was available on all of the sessions. That's something that we might not think that we need, but for some people that is a huge help. And that's something that should just be part of everything that we do. It shouldn't only be made available when a member requests it. It should just be part of our basic offerings to ensure accessibility for everyone. So think concepts like that. And that was another one of the recommendations we felt that NSGC could work on without needing that recommendation to come from the Exeter group, because we really thought that that was something that is beneficial to everyone. And we as a task force felt comfortable and confident making that type of recommendation.
And so in the Journal of Genetic Counseling you mentioned, we're going to link to that in the show notes for this episode. So you guys can go to dnapodcast.com, and any links mentioned throughout this episode are going to be on there. So I think it's important for people to be able to read that. And you had mentioned, I think before we actually started recording, that is available open access. So students can read it, anybody in the public can read it, which is amazing. And so that group you mentioned, the Exeter group, they're focused on really expanding the work that the task force is doing to come up with further recommendations for these strategies as we move forward. When it comes to genetic counselors and on an individual level, how can we as genetic counselors do better and be better in terms of looking at our patient population, our colleagues? How can we be more inclusive? What are direct actions we can start taking?
I truly believe the first step is really awareness. I don't think the majority of our profession really recognizes the health disparities that exist in the way that we practice. One easy recommendation that I think everyone can do is actually check out the 3 special issues of the Journal of Genetic Counseling this year on minority and health disparities in research and practice in genetic counseling and genomic medicine. I would especially recommend folks check out Nicola Carmichael's article from the first special issue on the experiences of minority genetic counseling students. Nicola also presented this data at the annual conference on Friday during the Best Abstract Award presentation. But I think those special issues are probably a great starting point for people to really take a closer look at how our current practices and beliefs really impact different groups. And I know 2020 has been a crazy year for a lot of people, and it might have gotten lost in the shuffle with the pandemic. But it was supposed to be one special issue, and Nadine, Lila, and Vivian did an amazing job editing this special issue, and it turned it into 3 because so many people submitted articles that I really think that's a great starting point. And then it kind of gives you the place to be like, okay, now I know that these issues exist. Where are places that I can really take action? Where are places that I can look at how I practice and what sort of policies that I'm involved in and help reevaluate those and rethink how I might be contributing to the problem. But I think that's probably a great starting point when we're looking at DEI within our profession and community. There's definitely lots of learnings you can do outside of it, but I think that's a great starting point. And then listening to your colleagues. There's plenty of our GC colleagues that I think have spoken up throughout this year, done podcasts, shared their experiences, or written about their experiences as students. And I really think we need to do a better job listening and not immediately reacting, but listening and really hearing what they're saying, and then reflecting on that before we react. Because there's definitely experiences people have had that we just were not aware of, or we might have turned a blind eye to because we didn't realize it was happening, or we didn't think anything of it when it was happening. And now thinking back on it, we're learning really how these experiences shaped our colleagues' experience as a genetic counseling student or a genetic counselor. And I really do think that we need to do a better job of listening to people and listening when they say and share their experiences and not minimize them or question them.
I think that's beautifully stated, and that we really need to be listening and bringing awareness to this and owning up to times where we have messed up. I think I've seen a couple tweets from you kind of mentioning that, of taking responsibility for what we've done and moving forward with that and learning from our mistakes, just like we do in other areas of life.
Yeah, I think we're really fearful of messing something up, so then we don't do anything because we just don't want to mess it up. And I think that's a huge problem if we don't do anything, because then you're just really kind of contributing to the problem by staying silent. And I think the best thing we can do is move forward, learn. If you mess something up, it's fine. It might not be fine at the moment, but I think we learn from the mistakes that we make. And if you don't make any mistakes, you really don't learn anything. And that's really where we need to be better, is with acknowledging those mistakes and recognizing how good intention might not mean that we didn't cause any harm. And so I think that's something that we also need to be very cognizant of, is that intent and impact can be two very different things. And even if you meant good intentions, but the impact was not positive, recognizing that and saying, okay, I'm sorry if that was not my intention, but I recognize and I acknowledge how that impacted you. And I really apologize for that. And I know now not to do whatever it was moving forward. And I've learned from it. And I think we have a really hard time recognizing that, or even making that first step, because we don't want to screw anything up. And I think that really hurts us in the long run.
And it's so important to be able to have these conversations. And sometimes, as you're saying, like starting them can be difficult, but we need to be having them. And that's how we're going to make progress with this. And so part of that conversation, especially with NSGC, over the weekend, was the NSGC Member Diversity, Equity, and Inclusion Survey. So this is something that was talked about in a couple different sessions that at least I was a part of. There was so much to attend over the weekend that a lot of it now we're going to be watching on demand into January. But for those that aren't aware, can you fill them in on really what the survey was looking to do and what were some of the outcomes from it?
Sure. So the role of the Exeter Group was really to assess our organization and work with the NSGC leadership and membership and staff so that they could kind of create and implement a DEI plan that was effective and sustainable and integrated into all aspects of our organization and activities. And so the first step of this was the membership survey for the entire NSGC membership, and it went out in mid-October. And for those that weren't aware, that survey specifically was really intended to assess engagement and inclusion, as well as cultural competency of the organization. So, and the survey also collected demographic information so we can explore differences between different groups of people and how they experience diversity, equity, and inclusion at NSGC through their membership. But some of the goals of that survey were really to examine how committed NSGC is to advancing DEI in the organization and profession. To what degree is DEI incorporated into NSGC's advocacy? To what degree does NSGC cultivate an inclusive environment across member demographics? So things like that. There's many other goals of the survey, but really it was to kind of create that baseline so we can understand where we are as a membership, as an organization, and a community. We don't really have the findings of that survey at the moment, but the second step from this survey, the survey was then utilized to create focus groups where we can kind of do a deeper dive into specific focus groups that were divided up based on maybe age, gender identity, work setting, race. There's 24 focus groups going on. So there's a bunch of different focus groups that members can take a look at, but also focus groups for non-members and lapsed members to really understand their NSGC experience, why they might not have renewed or why they might have never joined. And so the membership survey was really intended for that kind of baseline assessment and then used to dictate the focus groups. The only finding, as you probably saw from the conference, was really our response rate, which we had about 14% of individuals within our members actually responded back and filled out the survey. But the other kind of disappointing finding was that the majority of representatives of people that actually filled out the survey were actually from the non-majority groups. So most of the people that actually took the survey were the underrepresented individuals within the profession. So we really didn't have a ton of folks that were in the majority actually participating in this initiative. That was a little disappointing. But I do hope, as we were talking about, this is a learning opportunity for people to really learn that this was not really a great response rate. We need to do better. We as a community need to come together and help advocate for these resources or plans or whatever we might be doing, and that we should stay committed to contributing to research like this and contributing to the surveys. We all get survey fatigue, and that's definitely the case. But knowing that this is something that's been top of mind and something we've been discussing for a few years specifically now, since it's been on our strategic plan, that this was something that everyone should have engaged with and that we really could do better. especially when our professional status survey gets 50% or higher response rate whenever we send that out.
Yeah, I think that's well said in that, 14% of people actually did the survey, which to me is also very disappointing. Like the survey was really quick. It wasn't like you go on there and you're like, oh, this is going to take me an hour. Like I think it took me 12 minutes, something like that. Like it was really quick to be able to do. So, and that was something I think you tweeted that, people ask, oh, I don't know what to do. I want to contribute. And obviously we've talked about ways you can contribute, but this was an easy one. You click the link, you answer some questions, you're done. So, definitely disappointing that more people didn't fill it out, and just an example of like highlighting, hey, this is important. This is something that's really contributing to making progress. To switch gears a little bit, there was a session on the last day, on Sunday, that talked about when does expanded carrier screening turn into excessive carrier screening. And I have to say, I think this was one of the best sessions that I attended. I'm also a prenatal genetic counselor, so this was really important for me to jump into. And I mean, the presentation was great. Everybody commenting on Twitter, through the Zoom. I mean, it was on fire. It was amazing. And I think you were one of the top commenters there between Twitter and Zoom and everything. So, and for those that don't know, Aishwarya is the clinical product manager for carrier screening at Myriad, and so has a lot of experience in this. And just to disclaim for myself, I do order from Myriad's, and there's no financial interest in this episode. Like Myriad's not sponsoring this at all. 2 points I kind of wanted to pinpoint is kind of asking, why is it a problem to use general population carrier frequency of, say, like 1 in 100 as a threshold to say, oh, this carrier, this condition should be on carrier screening? And when we're making those decisions, what is the problem with using that as our threshold to say if a condition should be on carrier screening or not?
So I think the larger problem really is that ACOG guidelines suggests that you should use 1 in 100 carrier frequency when you're developing your expanded carrier screening panel, but they really provide no clarification whatsoever on what that 1 in 100 should be in. Is it any ethnicity, the general population, the US weighted population, or even why 1 in 100? Like, what is the reasoning behind the 1 in 100? None of that was ever provided. I don't think really, even until ACOG guidelines, the 2017 ACOG guidelines, the 1 in 100 carrier frequency really wasn't part of any guideline. And so that's really where more of my questioning is that if we're going to put something out like that, then we need to be very clear about what the criteria is, because depending on what the interpretation is, your panel sizes can vary drastically. And the larger issue is also, we just don't have updated carrier frequency information for many of the diseases on panels. Most of the carrier frequency information that is out there for some of the genes is really based on incidence data, and using that incidence information to then calculate what the carrier frequency is. And so I think we do need more published numbers around general population carrier frequency. And that probably is going to happen now that we've been doing kind of universal population screening for a while and doing general population screening. But for most of the time, we are using information from like the affected population, right? Because those are the numbers that are out there, and using that information. So I just think I'm all for using carrier frequency as a guideline, but I don't think it's the only guideline that we should be using. For example, even some of the conditions that are screened for commonly within the Ashkenazi Jewish community, such as Walker-Warburg or one of the Usher syndromes, wouldn't meet the 1 in 100 carrier frequency. So I think we just need to consider more than carrier frequency, maybe looking at the severity of the disease, whether there's treatment available, the sensitivity of whether or not, like, what your detection rates are across ethnicities for a particular gene. I think we need to look at a combo of different criteria, and that the 1 in 100 carrier frequency shouldn't be the sole thing that you use to say whether or not a gene is on a particular panel. And so that's really more of my critique, is that we shouldn't limit ourselves just to that one threshold, because we really have no kind of information on where that number came from. It's kind of like when we talk about 35 is AMA. And so like historically we know how that came about, but like, really, is that the best thing that we're using? Like, why are we using the numbers that we're using? Are there better ways for us to talk about panel design that are more useful and that are actually more scalable and easier to kind of create these panels? So It's not that I don't think that we should never consider a carrier frequency threshold, but really talk about what the purpose of that threshold is, who does it impact, does it reduce disparities, increase disparities, and kind of have that conversation when we're looking at what criteria we're using.
And certainly updating the guidelines sounds like the place to start with that, so that we are all coming from the same place, no matter what lab you're ordering from. There's a little bit more of a baseline that's a general consensus of the genetics community, so we can reach those goals with carrier screening. One of the other things that was coming up is about pathogenic variants, and if labs should only be reporting when they're finding a pathogenic variant. So for those that may not know that term, it's when we find a change in a gene where we say, oh, this change is causing the gene not to work. So there can sometimes be changes where we say, well, we think it makes the gene not work, but we're not sure. What are your thoughts? Should we only be talking about these pathogenic variants, or should we be having labs report all variants in terms of likely pathogenic, when it comes to this carrier screening?
So I really do strongly believe that we should report likely pathogenic and pathogenic. I think I'm in agreement with a lot of folks at the moment that we should not be reporting variants of uncertain significance on a carrier screening panel.
We'd be there
maybe
all day.
Somewhere down the line.
Yeah.
Yes, everyone will have a variant. Maybe we'll get there at some point where we are able to release that information. But at this point, I think it should be done on a case-by-case basis when providers need it or they need some extra clarification. But when it comes to pathogenic and likely pathogenic, I think we should be reporting both of those instances out, because when we're talking about likely pathogenic variants, they do have a high likelihood of being disease-causing. And I don't know the exact numbers on this, so you can't quote me 100% on it, but I do believe that when we're looking at likely pathogenic mutations, they're probably going to be mainly in those minority populations where we might not have a ton of disease information or case reports of these particular diseases in these patient populations, because we just haven't studied these populations or studied these diseases in those populations. So again, when we're talking about panel design, I think that's the other thing we have to talk about here is when we're talking about how we do testing and why we do testing, we need to look at who are we doing the testing for and how are we serving our patients? Are we only serving a subset of our patients? Are we serving a subset of our patients at a higher quality of care than our other patients? And for me, I think reporting likely pathogenic also allows us to kind of reduce those disparities more, because it's quite possible that we just don't have enough information in some of these underrepresented minority populations to call certain variants as definitively pathogenic. And I think restricting us to only reporting pathogenic variants could actually be harmful and really not accomplish really the true goal of carrier screening, which is to identify at-risk carrier couples. This is a screen. Like, that is the other thing to, I think, be cognizant of. It's expanded carrier screening. Nothing is ever going to be 100%. There's always limitations from a screening perspective, but our goal is really to identify those at-risk carrier couples and empower them so that they have the information they need to plan for their future kids, and however they want to do, like whatever action they want to take with that information, that's completely up to them. But we want to make sure that we're identifying these at-risk carrier couples and providing them with the information they need so they can figure out what they want to do as they build out their family.
Yeah, certainly. And I think reporting these likely pathogenic variants is going to push us towards that, to be able to better do variant curations across all patient populations. So thank you so much for coming on the show and sharing all of this expertise. I so appreciate you coming on, especially coming off of NSGC. I think we're all a little bit tired from everything. We're like tired from going through everything, but energized with, all the inspiration and everything, all the work we have to do in the future. So thank you again so much for coming on the show. Really appreciate hearing from you.
Of course. Thank you so much for having me.
Wait, you're still drawing pedigrees by hand in 2020? Don't worry, we have a solution for you. An intuitive digital pedigree drawing tool, part of Phenotype's complete genomic health record. Not only is it easy to use, it also allows you to capture complete family history accurately, 2.5 times faster than with pen and paper. And we all know time is very valuable in the clinic. Phenotips' latest feature, pre-visit patient questionnaires, saves you half the time of the first patient encounter by auto-drawing your pedigrees from the patient-entered information. Check it out and let us know what you think. Again, you can find them at phenotips.com. Phenotips might be familiar to you as they had a booth at NSGC this year. I'm also the host of their Phenotips speaker series, where I have interviewed genetic counselors about topics like telehealth, digital tools, leadership, and precision medicine. You can watch all of these on demand at phenotips.com, just like you're going to watch all the NSGC on-demand events. Just click the Stories tab on phenotips.com and stay tuned for future installments. Joining the show now is Rebekah Hutchins. She is a prenatal genetic counselor in Atlanta, Georgia, and she was one of the panelists for NSGC's More Than Just Raising Our Voices, Confronting Injustices in Patient Care. Thank you so much, Becca, for taking the time to come on the show today.
Hi, Kira. Thank you so much for having me.
So I thought we would start our conversation out talking about the cultural competency course that you developed, and I was honored to be in the first class that you presented this to. So thinking about the course that you've created with this, what should genetic counseling programs and other institutions include when they're looking at offering cultural competency classes and courses and having these conversations?
Yeah, so I've done it, changed a lot since you all have done it, but you guys were so well. Like, that was the perfect guinea pig class to like try it on. And I've added so much and taken things out and all kinds of things. But what I've heard the common problem is with a lot of these other, schools is that they either take some kind of like multicultural counseling course, which is good. They do get exposure, but the students are having problems connecting those themes, like things that they learn, back to genetic counseling, which is like the main reason that they even have that course. And so literally all you really have to do is just tie those major themes right back to genetic counseling. And I guess the best way to do that is to focus mainly on like racism and other kind of isms that are tied to the medical system, because there's a bunch, because our medical system unfortunately is inherently racist because it started out that way, unfortunately. But if you can just tie those back in and just try to like weave the web of like how these things connect to the problems that we have as healthcare providers, like medical mistrust and patient rapport and things like that, and like decision making and all of that can really help the students come outside of their comfort zone, one, and two, make those connections as to like how can my own personal biases and like explicit and implicit tie into what I'm bringing to my counseling session. So I feel like those are the best things to do.
Yeah. So diving into, being genetic counselors and really other healthcare providers, I think this can apply to everybody working in the healthcare space. But obviously we're genetic counselors, so that's what we're focused on. But for genetic counselors to be more aware of their explicit and implicit biases, but taking that a step further and saying, like, how can we be responsible and take action to diminish these biases and really take them head on and have these conversations?
Well, I think the first step, and they always say, is the first step is just recognizing that you actually have a problem. So if you think that you're doing great and that you're not counseling any differently and all your patient, connections are the same, I think you might want to reevaluate that. And one of the tools that is good to use is like the Harvard implicit bias test. Like, it's not perfect and it's very sciencey, like a research project, but it does at least get you in the right direction to recognize where your weak spots are, like where are you not recognizing certain things. And also just defining terms that everyone knows and have heard of, but actually haven't broken down and looked at the definition. So a lot of people have a issue or don't know the difference between race, ethnicity, and culture. And they're all very different and definitive definitions in themselves. They're very different words, but we all mix them and use them together. Even when we're taking like a patient intake, we use the same kind of language, but they're all very different and all have different facets. So it's just like those basic things, learning your terms, like just all of those things. I don't know what else.
Yeah, starting from square one of like, we can't have these conversations if we don't start out with the basic definitions, and then we can start having more of these conversations and people can be more involved and learn from there. You really have to start with the basics before you can get at anything more advanced, like anything else in life.
Yeah. Crawl before you walk. Exactly.
Yes, we got our pediatric developmental milestones thrown in there. I love it. So part of this panel was focused on the systematic barriers that are impacting access to care. And so one of that aspects with the panel that was focused on is how this is impacting specifically Black patients. Can you speak to this and what some of those barriers are, and what are ways we can start to dismantle these barriers?
Hmm. Okay, so basically the common thing that I've seen, not even in the Black community, but like a lot of marginalized communities, is exposure. Like they don't even know that like a genetic counselor is a part of their medical care. Like they don't know that a lot of times that it's someone that you should probably see at least once in your lifetime. Whether it be like you're pregnant and you're over the age of 35, or you have a family history of something, or cancer in your family, or heart issues. They don't even know what a genetic counselor is, how to get access to one, and also what good they are to them. And that's basically like the main thing that I've seen have kind of like from my patients, and also from just institutions that I've worked in, that patients don't even know that they should be seeing a genetic counselor at some point. Even when it's a part of just routine, like I'm just over the age of 35 kind of care, they just have no idea. So when they go and get scheduled for one, they're like scared, like, why am I seeing this specialist for something and I'm just pregnant? And it's like, oh, it's just because of your age, like you're fine. So I think it starts there. And I think it also starts with like insurance coverage based on like where you are, like if you have access to genetic testing at all. A lot of times genetic counselors are just looped in with physicians, so that part is taken care of, but the actual testing is not always covered, really depending on what kind of plan you're with, what kind of Medicaid or Medicare you have, and that kind of stuff as well. And also just like getting to clinic has also, I found, been like a big issue. Because again, a lot of patients are either on like Medicaid or some kind of government financial aid insurance that helps them get to and from the doctor as well. And sometimes those rides just don't connect with their other appointment times. And so sometimes they just miss appointments as well. So, but I think most of it is mostly just education and exposure to the field. Like they don't know that they should be getting it, therefore they don't get it.
Yeah, the presentation right before yours, Erica Stalling, she talked about how we need to do better at raising awareness within these communities. And that, you know, one of her examples was patients that Google Black people who have a change in one of their BRCA genes that's elevating their risk for cancer. There's not a lot of content out there in education materials that when you Google BRCA, it is white women that come up, and it's a lot of women that are coming from Ashkenazi Jewish backgrounds. And that's like a direct example of an area that we need to do better in, and having more content, and so that we're reaching communities that right now we're not doing, as you're explaining.
And that's a great point that you make, because even when I was an undergrad, my research was in breast cancer in African American women, and we are more likely to be triple negative. Like out of all of the ethnic, demographic groups, they're more likely to be triple negative and have really, really, really aggressive breast cancer. So yeah, I feel like that is something that we definitely need to do. Just exposing just our patient populations. But I actually am like struggling to think like where that even starts. Like, I guess it starts with the doctors, with the physicians, but it also should probably start like in school. Like they should know, like, when I go to the doctor, I see these people. But I guess like some of those things don't apply in a younger age.
But we have to start somewhere, right?
Yeah. We have to start somewhere.
It's even just reaching out of like, okay, where are people getting their content in general? And like, all right, how can we start putting genetic counseling in that and reaching these groups that, if they're reading a certain magazine, let's get an article in that magazine. Exactly. I mean, that's the way I think about it. I mean, obviously podcasting, that's where my head's at too. All right, who's listening to what podcast? Let's get on those podcasts. So I also wanted to, at one point you were talking about genetic counselors' role in research, and you had a really interesting experience as a student back when we were at Sarah Lawrence of seeing a genetic counselor that was involved in research. Can you speak a little bit more to that and what you would like to see in the future and right now, like tomorrow? What can we start doing in research and having patients' experience be better and building that trust?
Of course, yeah. So the example that I used was the research study team was called NY Kids Seek, and they were basically taking patient populations or doing whole exomes on patients in the Bronx, Harlem, and there's another group up there that they were using. But basically,
top of Manhattan and over, yes.
Yeah, probably Manhattan, just New York. Let's just say broad. But I was at Montefiore Children's Hospital, and I was with the amazing pediatric genetic counselors there. Shout out to Katie and everyone there. But anyway, so they would use their patients that they were already seeing and try to enroll them in this study. So with pediatric genetic counseling, as many of you probably know, you're going to see those patients over a period of time. It's more of a journey than something like, prenatal. So they already have like exposure to these people. And if you involve genetic counselors who are already seeing these patients as their own patients, a part of the consenting process, it makes that process so much smoother. I could just tell that the patients, they felt like they're not doing no weird experiments on my kid. Like, this is going to be handled really well. They were always really good about getting translators always in the room. Every time they did any kind of consent, they had translators the entire way. They also, rewarded their people who were enrolling. But the fact that they had the genetic counselors that were already giving patient care to go ahead and do consenting for that research project, I think made a very big difference on how many people actually were like, okay, I don't mind you all taking an extra tube of blood from my kid to be a part of this genetic study. And they've been having I think record breaking enrollment numbers. So I think that model was really, really good, because it's genetic counselors already know how to consent. We do it all day long.
Right, yes.
And so you're already working from their patient population who they're already seeing and following. So it was a really good research model, I think, with that.
Like the model that we're going to put on the pedestal to be like, this is what we aspire to be. Like, shout out to Katie Gallagher and everybody over there. No, they're fantastic over there. And I think that is a really good example of just like how we're building that trust. And genetic counselors, typically are really good at that. Beginning of the session, that's what you're doing. You're like, okay, we're building rapport here. And you continue doing that throughout all the sessions that you see them in. As you said, pediatrics, you're seeing them more so than someone like us in prenatal. We might see them once or twice. But I know we're running out of time, and I did want to ask you one more question. You are now a prenatal genetic counselor, but back a couple years ago when you were a student, just coming from that experience, how can genetic counselors in supervisor roles better serve genetic counseling students who are coming from minority communities? What can genetic counselors do to be better and educate themselves in this role?
So as a supervisor, I think it's, of course, I didn't really like the overbearing supervisor type. So, but just little comments or things that you can see that is making your student uncomfortable, when things like race or even asking the ethnicity question. That was really hard for a lot of students to get down. So basically what I was taught was I asked, what would you identify as your ethnicity? And if they're just like, what? I don't know what that means. Where's your family from? Did they come from anywhere but here? And then they usually just give a long list of all different kinds of.
They're like, well, my 23andMe says 20% is, blah, blah, blah. Yeah.
Which works, is helpful, but it's just a way for them to, get talking and see. And actually just not putting race on there, because race doesn't even answer the question that we're trying to get to. So it's just things like that. If your student is having a little hard time trying to figure out how to word things around culture things, or just are these kids from this pregnancy or from a previous partner? Those kinds of things. It's just, just stepping in and be like, you could just say it this way, or you didn't do a bad job. We got what we needed, but if you want to be more comfortable, try this way. Or just, giving them the keys, basically, helping them out and not just being like, that was terrible. That doesn't help anyone.
Yeah. All right, we've started with this. Let's see how we can, improve on that, sentence in the future and the way you're phrasing that. Well, thank you so much, Becca, for coming on the show. It's just a pleasure to have you and reconnect and everything. I'm so excited that you're continuing on with this education and that you're able to offer your cultural competency class. Maybe someday I can sit back in on it or something like that, but it really is fantastic. You did an awesome job with it.
Thank you so much. And thank you for having me, Kira. It was nice catching up and being able to talk. It's really nice.
We're making genetics fun, right?
Yes.
Thanks so much for joining me, Courtney, on the show here. We're going to be talking about the presentation you had at NSGC this year, Beyond Common Aneuploidies, Expanding Existing Chromosome Testing Technologies, and Subsequent Prenatal Care. So I thought we could start out with you kind of just defining what an RAT is for those that may not be familiar with. This was a newer term for me during the presentation.
Yeah, so a RAT stands for rare autosomal trisomy, and sometimes you may see it written as RAA, rare autosomal aneuploidy. And really, when we think about prenatal testing and screening, we're focusing on the aneuploidies we're most likely to see. So I often think of chromosomes 13, 18, 21, as well as the sex chromosomes. And RITs or RAs are essentially any other full chromosome aneuploidy that does not fall into those more common ones. So say a trisomy 8 or a trisomy 22, something like that would be considered a rare autosomal trisomy.
And so when there is one of these identified through NIPS usually, what should we keep in mind as genetic counselors in terms of the potential source for this? Because there's kind of a list that goes with that.
Yeah, definitely. And it really is based on how non-invasive prenatal screening works. And so this, as a finding on NIPS, could be indicative of true fetal chromosome mosaicism. This could be something that's in the fetus as well as the placenta. It could be confined to the placenta entirely, because that's what we're looking at when we're doing non-invasive prenatal screening, is really the DNA from the placenta. Could be something like a vanishing twin that resulted in an early loss but was never identified on ultrasound. Could be a terminal chromosome abnormality. Maybe mom is mosaic for something like Turner syndrome, or mosaic trisomy 8, something like that, that's at such a low level that they may have not even realized it clinically yet. It could be maternal malignancy, or it could be something that's just an artifact of the testing. There's always that chance that when we do a genetic screen that there is a finding that is not true, but really just an artifact of the testing itself. So it's really important to keep in mind all of these origins of these rare autosomal trisomy findings on NIPT.
And this is really good screening because we're seeing, as you said, cells that are coming off the placenta. So most of the time this is representing the pregnancy, but everything you just went through is cases where it's not necessarily accurately representing the pregnancy because we're not actually looking at cells from the fetus. Again, we're looking at placental cells, and sometimes there's that difference there that you outlined. When this does come up with testing, what are some of the clinical findings or outcomes from the pregnancies that are associated with these rare autosomal aneuploidies or trisomies that we're calling?
Yeah, so I think the most important thing to take away from this is that the most common clinical outcome or finding, if you were to see this on non-invasive prenatal screening, is a healthy live-born pregnancy, because a lot of the time this is not truly in the fetus, as you mentioned. But some other clinical findings or outcomes, if it is a truly representative of the fetus and in the mosaic state, it could be associated with a condition like mosaic trisomy 8, for example. It could be resulting in a miscarriage if it is in a level high enough in the fetus that makes it so it's difficult to progress and grow and develop. And if it's isolated to the placenta, it could be resulting in IUGR, or intrauterine growth restriction of that fetus, just because that placenta is not functioning at a level that it is supposed to be, and the growth of that fetus is suffering as a side effect of that. So these are all things that can happen with a finding like this on NIPS, and even in really severe scenarios, it could result in a stillbirth or a late loss in a pregnancy if it is affecting the fetus or affecting the placenta to a level enough that means that the pregnancy is not successful.
So knowing all of the outcomes that could be happening, the clinical findings that we're seeing on ultrasound that you mentioned, what should genetic counselors be doing in terms of options and counseling through with patients and educating them, not only about the different sources that you mentioned that could be resulting from this and, what we're seeing on for the outcomes and on ultrasound, but also just what testing should be considered at this point, and really how to explain that to patients so that they're following along with us.
It can be incredibly overwhelming, right? Because there is this long list of possible origins of this result. But I think as genetic counselors, we're trained to take information in and think of the most likely scenario and use a lot of the context clues to point ourselves in the right direction. So I think taking in a lot of the clinical information, what we know about this pregnancy, can help us counsel in a way that's more specific to a particular case. But a lot of the times we should think about what we did this test for in the first place. When we're doing this screening, a lot of times families, or they should be thinking of this, providing information about whether we're placing their pregnancy in a high risk or low risk category for aneuploidy. And if we get a high risk result for a rare autosomal trisomy, often the next step is offering diagnostic testing, preferably an amnio, to make sure that we're getting fetal cells to provide them with that answer. So I think that's always the first step. Depending on what chromosome it is, it may also be indicated to do a parental karyotype to check that box, or consider, could this be due to a maternal malignancy, especially if there are multiple rare autosomal trisomies or aneuploidies across the genome, and making sure we refer those patients to the appropriate clinics and centers to make sure that they get the best care. But I think the first thing is addressing this in terms of the risk for it being a true finding in the fetus and recommending diagnostic testing to provide that clarity.
Yeah, and for the diagnostic testing you're talking about is, if we look at doing a CVS or taking a little biopsy of the placenta and testing that, we're really looking at the same source that was coming from that blood test, the NIPS test. So as you said, amniocentesis is going to be better because we're actually getting fetal cells from that. And, as you mentioned earlier, one of the sources of this is mosaicism and having different cell lines. You have some cell lines that are normal, or you have two cell lines where one is normal, one is not normal. Why is it that, getting a little technical here, why is it that fish can find a lower level of mosaicism compared to karyotypes? So fish is where we use a probe to be able to highlight certain parts under the microscope, compared to karyotypes where we're actually looking at the picture of all of the chromosomes. So why is it that fish can find that lower level of mosaicism when we're comparing to doing a karyotype?
I think the bottom line here is that we want to look at as many cells as possible to get a high degree of confidence that we're ruling out lower level mosaicism. And with karyotypes, we're required to culture these cells to get those cells into a position where we can see those chromosomes in their most condensed state. And if we're thinking about an amnio here, we know that we need to get cells of unique origin, of unique clonality. And so we're looking at unique colonies of these cells, which requires a lot of material. So a lot of times, clinically, when we're doing this, we may run out of enough material to get to that confidence that we would like. Whereas fish does not require dividing cells, and it can be done on interphase cells that are not in that active division. And we can look at hundreds of cells at once, especially if we're talking about a whole chromosome aneuploidy. We can look at hundreds of cells. And if that assay is designed to detect mosaicism, it can give us more confidence that we're ruling it out in an amniotic fluid sample.
And one other point that I wanted to come back to as well is that you mentioned maternal malignancy, and that was also during this presentation right after your part, of genetic counselors kind of mentioning not only that maternal malignancy could come up with this testing, but in that pre-test counseling before a patient decides if they want to do this testing, of mentioning that. And I was shocked that 73% of live attendees that were answering the live poll said that they rarely or never mention this to patients before doing testing. So I just wanted to mention that because that kind of blew my mind a little bit. This is something that just as a prenatal counselor myself, I mention to patients so that they're aware of this. And the other thing that you were talking about too is that sending patients to the appropriate resources and centers for times that it does come up with maternal malignancy. There is it seems like relatively new study from the NIH called Identify, which is doing just this, of following patients that have had high risk for cancer coming out of this test. That's really a prenatal test, and it kind of crosses over into the cancer area. So just was surprised by that. I don't know if you expected more genetic counselors to say that they offer that pre-test counseling, or I just was surprised on my end.
Yeah, I think that when we are doing our pre-test counseling for any screening test, we're always thinking of the caveats. It's always thinking of those little asterisks that say, but this test could also tell us about these things. But I think in practice, it's so hard to cover everything you need for informed consent for a screening test about aneuploidy, putting those pregnancies in high risk and low risk categories for conditions like Down syndrome, and then at the same time cover all of the caveats. So I can completely understand why a lot of counselors aren't doing this. And I think about my own counseling, maybe I'm not as comprehensive as I should be in this area. But I do mention that there's a possibility that we could find out information about maternal health. And I kind of leave it at that umbrella term. So I think that unless more counselors are encountering this in their day-to-day practice, then it's less likely to be integrated into that pre-test counseling. But until you have a case like this, you may not think it's important.
Yeah, that's a good point. I mean, it's not very common that this is coming up, and it may become more common as more and more people are doing this testing during pregnancy. But that is a good point too, of just like you can do an umbrella term and kind of mention that we can learn about the mother as well as, the fetus and everything with this testing. But more common is coming back to the mosaicism. And there was another presentation about the transfer of mosaic embryos following PGTA, updates, ethics, and implications. And so I thought we could just in our last couple minutes here just cover a couple of the points that were brought up. And I think one of the main points for me was that PGTA is screening. This is something that I think we as genetic counselors know, but being really clear with patients that having their embryo screened for these aneuploidies, having extra missing chromosomes, this is not something that's a diagnostic test. It's still screening. And I know when I've mentioned that to patients, some of them may be surprised by learning that. And if they're meeting with me, they're already pregnant. So that was kind of one of my takeaways. Was there anything that you found interesting in that presentation?
As a counselor that does counsel for PGTA all the time, it's definitely something that's more frequently on my radar when I'm practicing, but it's always so interesting how these relationships with your patient and discussion of mosaic embryos and individual patient priorities, as well as their level of risk that they're willing to take on, as well as an institution's level of risk that they're ready to take on. It gets into a very nuanced conversation. And so I appreciated how this session handled those nuances and talked about the ethics involved, as well as the concrete steps that we can take as counselors to best handle these cases and make sure that our patients are informed as possible before considering a mosaic embryo transfer.
Yeah, definitely. I think this is one to definitely rewatch. I think I've been cramming with so much information the last 5 days that I'm like, there's certain ones I need to go back and rewatch and take better notes on and everything. But I think that's a really good point of just everybody's going to be a little bit different. And there's, as far as I'm aware and what the presenter said, that there's no guidelines right now for in general in the US of what we're doing with mosaic embryos. So I think this is something that I've definitely mentioned on the show before. I think there was an episode in the fertility series earlier in the year where we explored this and just like, where are we at with mosaic embryos, and to keep your eye on it. And before we close out, Courtney, there was another session that you wanted to mention and kind of your recommendation for people going back on the on-demand side.
Yes, I always love the Janice lecture at the annual education conference because it really highlights a genetic counselor that has a mastery of particular material within their specific specialty. And this year it highlighted cancer genetic counseling specifically for ovarian cancer and working within the prenatal realm. A lot of the times I don't think too often about cancer genetic counseling, but it was a great reminder about how we can all be looking out for ovarian cancer in family histories and making sure that these patients get the referrals that they need because of how frequent causative mutations are found in individuals with ovarian cancer, and making sure that those individuals are getting the care that they really need. So it was a great lecture. I recommend it for anyone who's going back and watching those lectures on demand.
And that we can watch lectures on demand till January 15th. So something to do over the holidays and everything. So thanks so much for joining me, Courtney. It was great to reconnect and everything. For those that know us, we were in the Diagnostic Genetic Sciences program at UConn. So always good to reconnect. And now we're kind of both on the same page being prenatal genetic counselors. So thank you so much for joining me on the show today.
Thank you for having me. Always good to talk genetics with you, Kira.
Joining us now is Ashlyn Enokian. She is another prenatal genetic counselor. Thanks for coming on, Ash.
It's great to be back, Kara. Thanks for having me. The title of our poster was Impact of Psychiatric Genetic Data on Tort Litigation and Its Relationship with Stigma.
So this was our thesis project at Sarah Lawrence College. So this is how we became genetic counselors. This was part of the graduate studies that we did. And so we actually talked about this almost 2 years ago now, back on episode 101. So you can hear more about how the thesis project started and kind of general grad school information on there. And Ash was on the episode last year for NSGC for 2019. So thanks again for coming on and kind of sharing with us today of like what our poster was talking about. And this is what we presented at NSGC this year.
I think we had a really unique and interesting study where we explored how judges may or may not be influenced by genetic evidence, specifically that was in relation to schizophrenia in the tort litigation space. So when you're thinking about civil court, where people are sued for negligence or violating a protected right, more that side of the system rather than the criminal court system that I feel like we all are more aware of, you kind of know and love in kind of mainstream media, TV, that kind of side. Fun fact, this is actually the first study that analyzed this kind of relationship.
So it was awesome to be a part of this. And to do this, we surveyed 465 state trial court judges. So they completed a survey that presented a story where a driver experienced hallucinations and delusions that led to a car accident. So some of these stories stated that there was genetic evidence for the driver's schizophrenia diagnosis, and other stories that judges had didn't state that there was genetic evidence. So that was kind of one of the factors that was different between the two. And we had two main findings out of that.
And surprisingly, genetic evidence seemed to have little effect on judges' decision-making, which was something that was very surprising for Kira and I and for everyone kind of taking part in the study. I think just because we come from a totally different angle than what judges come from. So we probably, expect different kinds of findings, but over half of the judges considered the driver's schizophrenia a biological disorder, qualifying as a physical disability, which was a very, very important finding.
And it's important because we can think about how this could impact law in the future. So if schizophrenia was redefined as a physical disability as opposed to what it is now, this could result in policy changes regarding the standards for responsibility for behavior in these civil cases. Again, we're thinking civil, not criminal, for individuals that have schizophrenia. So how judges are viewing this and what sentencings, rulings, decision-making is going around that if someone has a schizophrenia diagnosis and we're seeing that as a physical disability as opposed to being more of limited to the psychological extent. So that was just an interesting part that came out of this study for us through our thesis project at Sarah Lawrence. So we are really scratching the surface here and only hitting the highlights. So check out the poster for more information, and you can find that on dnapodcast.com, and you can just click on this episode's blog post. It's number 135, and it will pop right up. It's also available, as I mentioned, through January 15th through NSGC. So you can go to the posters, and I believe it was poster 172. I hope I'm remembering that right. But if not, it's at dnapodcast.com.
And we just want to say thank you so much to Laura Hersher and Dr. Maya Sabatello for being both our Sarah Lawrence mentor and advisor and for guiding us through this process.
Definitely. Well, we'll definitely hear from Ashlyn again in the future. So thanks for popping on.
Thanks, Kira.
And two other random session shout-outs. The first one, Pariah or Pioneer, Stories of Expansion into New and Emerging Genetic Counselor Roles. The second one, Mastering the Art of Advocacy Through Media Relations, which shouldn't be a shocker to anyone coming from a podcaster. So for more information, you can go to nsgc.org or check out the blog post associated with this episode at dnapodcast.com. As I mentioned, we link to lots of articles mentioned today, specific tweets and tweet threads, our poster. We include links to all of the guests today's social media, including Twitter and LinkedIn, tips for the virtual conference, as well as tips for when it is in person again. So much information in this blog post. Go to dnapodcast.com to access all of that. You can search DNA Today on Twitter, Instagram, YouTube, Facebook, and connect with us in all those places. Any questions you have coming out of this episode and just attending NSGC, if you want to share your experience, email in info@dnapodcast.com. And one quick favor, please rate and review if you're listening to this on a podcast player. We so appreciate the support and love we get from you listeners. This is how the show can grow. So please rate and review, especially if you're listening to this through Apple. Thanks for listening, and join me next time to learn and discover new advances in the world of genetics.
Genes of you and me, genes of you, and we're all made of DNA. We're all made of the same chemical DNA.